everybody. My name is Vanessa Stewart Aycock, and I'm a health education specialist for the Department of Veterans Affairs here in Orlando, Florida. And my topic today that we're going to discuss and explain in regards to is the telemedicine in the hospital setting. Our objectives for this program that I'm going to present these slides is to describe telemedicine, discuss challenges and barriers to telemedicine in the emergency department, describe the benefits of telemedicine, explain how it relates to modeling and simulation, and explore why it's important and how is it used today in a local emergency department here in Florida in the Orlando area. So telemedicine is the use of telecommunication and information technologies in order to provide clinical health care at a distance. Some of the key points that I was able to find in the literature is that it's a product of the 20th century telecommunication and information technology, and there's three types: store and forward, remote monitoring, real-time interactive, and the first interactive telemedicine system operating over standard telephone lines was established in and around 1989 by an American company called Medphone Corporation. Some of the benefits for telemedicine for patients that live in isolated areas and the specialty isn't available. At the Florida Hospital Emergency Department where I work per diem, we have the telemedicine for neurology for our stroke center. We were certified as a stroke center about 6 months ago, and we have an available online neurology acute stroke physician who we're available 24/7. They were able to dial in and start the telemedicine prompts so that they can assess the patient right along with us. Multiple providers or specialists can collaborate regarding the patient's care when they are not all in the same place. That's one of the benefits. Patient monitoring, which reduces the need for visits to the office and facilitates education and training to staff while observing best practices. So while we're conducting for example, in the ER, conducting the physical exam for the neurologist, he's able to give us guidance on how we're conducting that exam. And we're able to see best practices when he has given us the directions on how to do that. It also benefits eliminating possible transmission of infectious diseases between the patient and the staff, especially if you have a patient who's doing wound care and he may have MRSA or some other possible transmission of an infectious bacterial infection. You can still observe that wound and how the dressing changes are going without the physician or nurse being present, or the patient having to come into the emergency department, or not emergency department, sorry, into the physician's office. Some of the challenges: the data management and technical training of staff who deploy it. So of course you have to have those experts who are deploying the devices in order they work properly, and also managing that data. Decrease human interaction. Some patients want to have that human contact with their physician, and they want to be able to see the physician in the office and spend that time with them. There's some liability and HIPAA challenges that have to be overcome related to securing of patient information, even though it's going across the wire. Increased risk of error when the patient isn't seen in the office. Reimbursement concerns with insurance companies and government-controlled reimbursement. It decreases time efficiency. There was one study that I read that in some cases for dermatology, appointments in the office are about 15 minutes, but when they do it online, the appointment has a tendency to be longer, up to 20 to 30 minutes when they do it by telemedicine. There could be poor quality of images or sounds with voice when you're able to try to talk to the physician online. And there's movements of the patient that may be delayed. We've had some issues with our sound quality sometimes on our telemedicine device, and we've had to revert to having the physician call our phones directly into the room, which has worked. But again, that is one of the challenges that we face with technology. This is a graphic depiction of the telemedicine concept where you have the district hospital that's able to dial in with the specialty hospital that could be many, many miles or hundreds of miles away. Also with the ambulance down there at the bottom, they can also dial into district or specialty hospitals for assistance, whether it's related to pathology, cardiology. They could do video conferencing, as well as have a panel of physicians. I think of pathology of certain cancers and those sorts of things. You could have a panel of physicians in a room, and they could look at those slides and do those case presentations by telemedicine. The state of the art with telemedicine, the research in the area, it's been 40 years of research related to cost effectiveness and efficacy of telemedicine. There's over 12,000 citations published of works of telemedicine, and there's 2 established journals devoted to telemedicine that's evidence-based journals, as well as there's at least one professional organization I was able to find, and it's called the American Telehealth Association, and they have conferences annually. Future possibilities for telemedicine, consumer-focused wireless applications and improvement in e-health, including patient portals that patients can pull up their medical record online and talk directly to their physician. There's some physician offices here in Florida that are already doing that for patients to look at their labs and x-ray reports and those sorts of things. There's already for many years emails that physicians respond to when you have a portal that you're able to enter an email question to your provider. Continued decrease in periods of hospitalization. So it's been shown in the literature, if you're able to do the telemedicine or have some sort of contact with your patient, you're able to decrease the time the patient has to be hospitalized. Optimization of therapy using guidelines and protocols. For example, acute stroke management with thrombolytics, which is what our emergency department does now. It totally optimizes our therapy without having to send the patient to another facility and waste that time, while we're able to use the telemedicine physician online to do the acute stroke management with the thrombolytics. The relationship to modeling and simulation, there's a virtual reality in simulation. It correlates nicely, I think, with telemedicine, the use of avatars. So you could have avatars that could simulate that they're having a stroke, and then the physician would be there to be able to evaluate that patient. It's possible to run scenarios with simulated patients for the physician or the mid-level provider to practice those communication skills when you're trying to do the NIH stroke scales or any of the stroke scales that are available that your facility may use. The provider can practice with the remote team on the skills necessary to examine the simulated patient. For example, like I just mentioned, the NIH stroke scale. So you can practice those scenarios in the lab and then use those practice scenarios in order to firm up your training for your staff before you go live with your simulation, or I'm sorry, before you go live with your telemedicine for your neuro patient, for example, like I mentioned in the ER in Orlando. How's it used today? So what I'd like to talk about here for a couple of minutes is the 30-bed local emergency department where I work per diem. We were recently certified as a stroke center, and one way we were able to do that, we have to have 24 hours, 7 days a week coverage if a patient comes in with the signs and symptoms of a stroke. So the nurses and physicians, we were all trained on the protocol and process for utilizing the acute stroke physician, which is an on-call service that's been established for the hospital Monday through Friday, 7A to 7P. There is a neurology physician that's actually stationed at the hospital. There's a neurology group that actually covers the hospital during the 7A to 7P time period, Monday through Friday. But after that, on the off tour, the acute stroke physician is available by telemedicine in the ED, where during those other times the neurologist actually comes to the emergency department and sees the patient. So when a patient is determined to be a code gray, that's our mechanism to overhead page everyone to come to the emergency department as well as the neurologist. It's a patient who presents with stroke-like symptoms, and we have a list of symptoms that we would go by. The protocol is initiated, which starts with a non-contrast CT of the head within 5 minutes of presentation to the emergency department, and that is either by ambulance or if the patient comes in through the front door. Then the telemedicine device is rolled into the patient's room, and that's during those off times of the 24/7 coverage, and the neurologist is not in the emergency department available. The connection is made, and the acute stroke physician is on the screen to discuss the case, and along with the nurse and or the ED physician, we conduct the physical exam at the direction of the acute stroke physician on screen. And so basically, he asks us to do a certain series of steps for that physical exam. He gives us directions on how to do that. And like I said before, the last one that I was involved in, there was a connection issue with the, we weren't able to hear him. He could hear us, but we couldn't hear him. So he ended up dialing in on a separate phone line in order for us to make that connection. From there, the acute stroke physician, along with the ED physician, make the determination of what path the patient will proceed on the protocol, whether that's going to be the giving of thrombolytic therapy or the patient will be admitted to the ICU for continued observation. There are evidence-based practice power plan physician orders that are used to facilitate the care of this patient, and we have those in a folder so that all goes into the patient's room, and along with the ED physician and the acute stroke physician, those orders are completed online and initiated at the time of the discussion with the acute stroke physician. The American Heart and Stroke Associations are recommending, due to the relatively low number of stroke specialists in the country, deployment of telestroke in appropriate areas for diagnosis and treatment of both acute and subacute stroke. So they're also recommending that centers use these stroke physicians as the expertise in the area to help with decreasing the life-threatening results of stroke if it's not identified and treated quickly. Telemedicine for the stroke care could also improve secondary prevention of stroke. That's another reason they're recommending, American Heart is recommending telemedicine. It also helps improve the prevention of stroke as well, especially if it's a TIA or a transient ischemic attack, and the physician specialist recognizes that is the diagnosis, and the patient can be admitted and prevent the full stroke from happening. So barriers for telemedicine in the ED specifically: regulatory challenges related to the difficulty and cost of licensing issues and malpractice and liability. Those are worked out, of course, through your quality management teams, but those are some of the barriers that have been established and that they're working towards. You have to work towards those to resolve. Reimbursement by insurance companies become a battle. There's certain codes for reimbursement for insurance companies, and those are always a challenge to work through the menagerie of insurance claims and reimbursement. And then there's the culture changes that some physicians may lack the desire or even the willingness to change to this type of application for caring for patients in the ED. Our physicians so far have been very receptive and willing to use the telemedicine. There's been no pushback from any of the nurses or physicians that I'm aware of, and it's been a great saving for us to be able to keep our patients in the emergency department, get them the care they need quickly, and use the thrombolytics, and you're actually able to see right away the actual outcome that the patient improves with the use of thrombolytics, as opposed to us having to transport them out of the hospital. So this is basically what our device looks like. You can see there's a PC You basically plug it in, turn it on, the physician pops up on the screen. It's like Skype, basically, and you're able to have the discussion with the physician. He gives you the directions on how to have the patient do the scale, as far as the NIH stroke scale is the one that we use, and we go through those steps of the stroke scale and do the score. He actually does the score along with you, so that you're able to determine the score at the end of doing the scale. And then you unplug it, and we put it back in the closet where it's stored, and it's secured. This is a picture of one of the physicians actually doing part of the stroke scale, and you can see the physician on the TV also showing what they want the patient to do. This picture was one that is showing the patient had a head injury, and he's asking him to hold up 2 fingers. So the physician's actually able to do his own neuro exam without even being in the room for a patient that could possibly have a head injury. Okay, that ends my presentation. If you have any questions or you'd like to email me, there's my email on the screen, and I would be more than happy to offer any questions related to the startup of our stroke center in the emergency department using telemedicine in the Florida area of Orlando, and it's the Kissimmee Emergency Department. So if you have any questions, feel free to email me, and I would appreciate your feedback. Thank you.